is a flat sheet of deep fascia. Flat sheet of deep fascia. Epicranial aponeurosis. This is formed of dense irregular connective tissue. Is a thick inelastic whitish membrane which covers the scalp. In the anterior end of it to the front, over the front, contains muscle fibers, which is called the frontal belly of occipitofrontalis. On the posterior aspect, just before its attachment to the external superior nuchal lines and external occipital protuberance, again contains muscle fibers, which is called the occipital belly of occipitofrontalis. So the three layers: skin, connective tissue, superficial fascia, and then you have epicranial aponeurosis containing muscle of occipitofrontalis on the anterior and posterior end. And on the lateral sides, again, contains few muscles of what is called the few muscle fibers, occipitotemporalis, temporalis muscle. Now, next to these three first layers, the skin with connective tissue and the epicranial aponeurosis, these three layers, they fuse with each other. And when you put your hand, if you put your hand over your head and start to move the skin of your head on the calvaria, the layers move together. The portions which you move below your finger are the three layers: skin, connective tissue, and the epicranial aponeurosis. These, they move on the fourth layer. So these three layers are attached to each other firmly, and they form as if they form a single layer which can be moved by finger pressing over the head. You can move these three layers together. Next to these three layers, the fourth layer is formed of loose areolar connective tissue. This is a tiny space containing loose areolar connective tissue. Loose areolar connective tissue, and the aponeurosis is loosely attached to this layer, so that the first three layers, we can move them over this layer. Now, this layer doesn't contain vessels and nerves, except those which join the emissary veins, which join the veins of the scalp to the veins of the cranial cavity. Next to the loose areolar connective tissue, the last letter, which is P, this is the pericranium, the covering of the bones of the skull, which is called periosteum. Again, is formed of dense irregular connective tissue. This is attached to the surface of the bones, cannot be separated from the surface of the bone. The periosteum of the bones is called pericranium because it's the bones of the cranial cavity, so we call it pericranium. It's the periosteum of the bones. So these are the 5 layers of the scalp. So the scalp covers the calvaria from the superior nuchal line to the supraorbital margin, laterally extend to the zygomatic bone. 5 layers, as I said: skin, cutaneous tissue, which is superficial fascia, aponeurosis, loose areolar tissue, periosteum. The first 3 layers, skin with the cutaneous and aponeurosis, connected with each other and form a single layer and move as one unit when you press over the bones of the skull. The skin is thin, except in occipital region, because in the back, the skin, all parts of the body is thicker than in the anterior parts. Contains, of course, sebaceous glands, sweaty glands, and a lot of hair. And this has a good blood supply and lymphatic drainage. Next is the subcutaneous connective tissue. This forms thickness, richly vascular area. As I said, all the nerves and vessels are present within this area. The epicranial aponeurosis is a deep fascia derived from the deep fascia, strong tendinous sheath, covers calvaria between epicranius muscles, the occipital belly and frontal belly, with on the side the occipitotemporal and superior auricular muscle. Below these 3 layers is the loose connective tissue. This allows a free movement at first 3 layers over the calvaria, a spongy potential space which may distend with fluid or blood from infection or injury. This occurs when you hit your head by trauma, or you hit it on anything. This might lead to accumulation of blood due to rupture of these tiny emissary veins, vessels there, or sometimes infection occurs and might lead to formation of abscess in this, and then it bulges to the outside without any blood coming from the outside. Next, we have the pericranium, which is the periosteum of the skull bone, and is firmly attached to the bones of the skull. Now the scalp, the blood supply of the scalp, as I said, all vessels run in the second layer and are held by connective tissue in such a way they remain open when completely cut. So they bleed profusely and heals quick. So there is a cut injury of the scalp where it cuts the three layers, then this bleeds profusely. But the partial injuries usually doesn't bleed profusely because there is no complete gap. Now the arterial supply is through the external carotid, branch of external carotid. The occipital artery supplies the posterior portion of the scalp, superficial temporal supplies lateral side of the scalp, and posterior auricular behind the auricle. These are branches from the external carotid. Sorry. From the internal carotid, you have ophthalmic artery. The internal carotid is the blood supply, is the main supply of the brain and the cranial cavity, but this ophthalmic branch which supplies the orbital contents and the eyeball give branches which emerge to the scalp, and these are supraorbital, if you remember, which emerge from the supraorbital foramen in the skull and pass upward to supply the anterior portion of the scalp, together with supratrochlear artery which emerges near the medial angle of the eye and descend again to the front. So we have different sources, and there is a lot of blood supply to the scalp. This gives the clinically is important because once there is injuries, then they bleed profusely. There will be a lot of bleeding, but at the same time, this has an advantage that the wounds will heal quickly because of this rich blood supply, bringing more oxygen and more nutrients. So healing is quick. So the blood bleeds profusely but heals quickly. Now nerve supply is sensory. You feel pain, you touch, temperature in the scalp. Now anterior to the auricle is by branch of the trigeminal nerve, which is the fifth cranial nerve. V, it's 5 in Latin word, which is the trigeminal or fifth cranial nerve. Again, we have the same, just like the arteries, supraorbital and supratrochlear, from the ophthalmic nerve, together with zygomatico-temporal from the maxillary, and auriculotemporal supplying the lateral side from the mandibular branch of trigeminal nerve. To the posterior half of the scalp, this is supplied by branch from the cervical nerves, from C2 and C3. Cervical spinal nerves, and these are great occipital which pass to the back of the skull, lesser occipital again ascend medially from the C2, and the third occipital. From their name occipital, they supply the scalp over the occipital bone, the posterior half of the scalp. So anterior half of the scalp is supplied by branch from the trigeminal nerve. From ophthalmic, we have supraorbital, supratrochlear. From the maxillary, we have zygomatico-temporal and auriculotemporal. The posterior portion is supplied by branch from the cervical spinal nerve, C2 and C3. These are great occipital, lesser occipital, and third occipital. Now the veins accompanies the arteries. Emissary veins, these are small channels joining the veins of the scalp with the veins of the brain, which we call them venous sinuses of the brain. We have If you remember, in the skull we have parietal emissory foramina on each side of the sagittal suture. In the middle, they communicate with the superior sagittal sinus. We have mastoid emissory foramen over the mastoid process that again communicates with the with the sigmoid sinus. So these are short channels communicating veins of the brain together with the veins of the scalp, and these sometimes might be the source of transmission of infection from the scalp toward the cranial cavity and might lead to meningitis, Sahaya. Lymphatic drainage. There is no lymph nodes in the scalp, but there are lymphatics. The lymphatics drain to lymph nodes at the junction of head and neck. They drain to the submental below the mandible, to the submandibular, again below the lateral aspect of the base of the mandible, to the preauricular, or we call them superficial parotid, lies anterior to the auricle, or sometimes even are called preauricular. Then we have retroauricular or mastoid, and occipital, lies along the superior nuchal line. So the lymphatics are present in the scalp, but no lymph nodes inside the scalp. They drain to a chain of lymph nodes which surround the junction of the head with the neck. As I said, scalp injuries, partially detached scalp, but it's only injury to the skin and the superficial or the cutaneous tissue. These might be replaced with reasonable chance of healing. It's small scalp injury. They doesn't bleed a lot and they heal very quickly. If there is a complete cut of the scalp, this bleeds usually profusely because of pulling of the occipitofrontalis, one from each side, and connective tissues surrounding the arteries and the veins, holding them not to be closed, so there will be a lot of bleeding. But again, they heal very, very quickly. Usually the complete cuts, these they need suturing, but the superficial ones, they usually doesn't need suturing. Sometimes the scalp might be partially detached. Anybody have seen movies of Red Indians in the United States? There's a lot of movies about the Red Indians. الهنود الحمر أيام زمان من كانوا يقاتلون يكون واحد العدو مالتهم سكينة يقصون السكالب مالته from the side to side, and then they remove it. They do what is called avulsion of the scalp, and in this usually they remove all scalp, and then you will see the loose areolar connective tissue with the pericranium or periosteum whitish over the bones. This can be replaced. You can suture the skull, and usually it might heal. Now, loss of scalp does not produce necrosis of skull bones because the skull bones, they doesn't take their blood supply from the scalp. Blood supply of the scalp, as I said, all lies in the second layer of the scalp. And then if you remove the whole scalp, the 3 layers of the scalp, then the bones doesn't undergo any necrosis. They remain as such because their blood supply is from different sources, from the inside of the cranial cavity. Those which lie within the scalp, they supply only the 3 first layers of the scalp. Infections of the scalp usually occurs in the 4th layer, and this could spread to cranial cavity, as I said, through the emissory veins, leading to meningitis, which is inflammation of the covering layers of the brain, Sahaya, or even sometimes rarely might reach to the brain itself, leading to encephalitis through emissory veins. It might descend infection to the eyelids, but not posteriorly or laterally, because the laterally and posteriorly the epicranial aponeurosis fuses with the bones, with the zygomatic arch and with the superior nuchal line. But it descends to the eyelid, because this is continuous with it. Anybody have experienced this? Sometimes when you hit your head, then the second day you will wake up and you will see that all the eyelid, upper eyelid is turned into black. When there is injury in the third layer and the fourth layer, in the layer 4, then the blood will descend downward to the eyelid by gravity and accumulate there, leading to what is called black eye. We call it black eye. This is because the blood descent and the anterior aspect of epicranial aponeurosis is not attached. It blends with the eyelids, with the tarsus of the eyelids, so the bleeding or pus, even if there is infection, it might descend to the eyelid, leading to swelling of it. And if it is blood, then it appears blackish, blue, dark bluish to blackish in color, and this we call it black eye. Again, scalp lacerations, partial wounds, they doesn't gap, but the complete usually gap, and a lot of bleeding will occur. So they bleed profusely, but they heal again quickly. Sebaceous cysts, these are cysts which occur due to inflammation of the sebaceous glands. Sebaceous glands, again, a lot of you might, during this time, you might have a lot of these sebaceous, small sebaceous cysts. Sometimes they become enlarged and become large. Cephalohematoma, cephalo, this means head, and hematoma, it means that, as I said, when there is no injury, you might have bulging of the skin of the scalp when it's hit by trauma without wound, without any open wound. Bone flaps, these are for the repair of the fractures of the bones of the scalp. Do you have any questions? Anybody? No one has any question? Are you with me? Anybody? Just say hi or raise your hand. No questions? So we have finished with the scalp. Yes, anybody?
No, thanks.
Okay, we will move to the next part, which is the face. Now the face, all you know that everybody has its own shape of its face. No one looks exactly like other except the identical twins. Otherwise, everybody has its own shape, and the basic shape of the face is determined by underlying bones, which is determined again genetically, and by the buccal fat pad. Buccal fat pads on the sides or on the cheeks on each side. Looking to this face, what we see that it's covered with the skin just like any other part. The face starts from the front, which is continuation of the scalp, and then looking to the face, what you will see landmarks. You will see, of course, this is the front. Here is the front. Below you have the eyebrows at the supraorbital margin on each side, and then downward on each side you have the orbit containing the eyeball, and the eyeball is covered with two eyelids with a fissure between them, where we can see the cornea, the pupil, and the conjunctiva. The pupil, the cornea, and the conjunctiva. Conjunctiva with the two eyelids between them is the palpebral fissure through which we see the eyeball. The eyelids, again, at their free border, they are covered with 2 to 3 layers of hairs, which we call them eyelashes. If you look the direction of the eyelashes of the upper eyelid, These are directed forward and backward, curved, and then upward. Upward and backward. Those of the lower eyelid, they are directed forward, downward, downward. And this makes that when blinking your eye, the eyelashes will not intermingle with each other. This is because of this curved course. Those of the upper eyelid upward, those of the lower eyelid downward. The girls, when they put what is called the mascara, they know how to turn the brush of mascara over their eyelashes. They put it on the upper eyelashes, first forward, roll it, and then roll it upward and backward, the reverse for the lower eyelid, bringing it from below and then anteriorly and downward. Next, to the orbital margins. We have between the two orbital margins, we have the nose. Again, the shape of the nose, the size of it differs from one individual to the other, between males and females. Then you have the nose, you have the two external areas. On each side of it, we have the two cheeks. Then we come to the below the nose is the two lips. Here is the upper lip. The upper lip you see is formed of three portions, two lateral on each side and the central depressed portion. The central depressed portion, we call it philtrum of the upper lip, and these two lateral portions with these two ridges between them. Then you have the lower lip, which is formed of single part. The lips are covered with the skin, but then the border changes to mucous membrane, where it's look like pinkish. This stratified squamous orthokeratinized epithelium, changing from skin to the squamous membrane. This border of changing, line of changing, we call it vermilion border. The size of they appear pinkish because of the mucous membrane is thin and the blood vessels are very near to the surface, so they give them this pinkish color. Of course, females all the time, they are painting this with what they call the lipstick, through lipsticks of different. Previously, it was only red lipstick. Nowadays, they use all the colors from white till the dark black. The size of the oral orifice between the two lips also is determined genetically. Some of the people they have a small, some they have medium size, and some have very large oral fissure between the two lips. Then descending to the lower border of the face. This is the lower border of the face, which is the base of the mandible till the angle of the mandible. This below this is the neck. On each side, of course, we have the two auricles, which are the part of the external ear. So these are the landmarks over the face. Now, one of the differences between male and female is the hair distribution on the face, which is one of the secondary sexual characters. Is one of the secondary sexual characters, where the males after puberty they will have hair on their cheeks and chin and the upper lip, the mustache, while the females doesn't have this hair. Now, in addition to this, the skin contains transverse grooves, especially on the front. When you elevate your eyebrows, then the skin of the front will pass into transverse grooves. These are, we call them skin wrinkles. Now, all these in the face, they run transversely, even, and in old age, these become very apparent all around the eyeballs and even around the oral orifice, and all of them, these run transversely. And this is important in doing surgery on the face. You should cut transversely like that, so that healing will be better than if you have vertical incisions in the skin. So this is for the surface anatomy of the face. This is the normal looking of the face. If you see an abnormality, a bulging here, this means it's abnormal, or here or anywhere. So if you know the normal, then you